everyone. My name is Jane Dwyer Lee, and I'm a teaching professor at Florida State University. And it's my pleasure to present to you today this webinar workshop on substance use disorders. The Florida Higher Education Substance Use Disorder Consortium is a multi-university project led by FSU and the NASW Florida chapter, Disc Village, and Citrus Health Network, Inc. We were tasked to develop a science-informed curriculum concentrated on substance use disorders. Also, co-occurring mental health disorders. And we will move to developing a substance use disorder professional certificate. Do you think there's a current need for a professional certification specifically designed for social workers working in clinical settings? Just think about it. I do. Social workers represent a crucial profession working on the front lines of addressing and treating substance use disorders nationwide. Substance use disorders have important implications for the health and well-being of individuals, families, and communities. Social work education must rise to meet the workforce needs and incorporate alcohol and other drug-related content into social work programs, particularly in the foundational curriculum. The stigmas engulfing drug and alcohol misuse are dissipating. There has arguably never been more discussion, more community action, more political action, or more media reporting on substance misuse than there is today. To date, there is a consensus that the field of social work has not worked as effectively as it could or should with individuals who have substance use disorders. As a matter of fact, the 2016 U.S. Surgeon General's report on substance abuse observed that the social work profession is failing to adequately prepare students to deal with substance use disorders and associated problems. In short, social work education has not advanced to meet workforce development needs to date. And there is no reason to believe that this standard will change without focused leadership on this very distinct problem. In previous research, faculty across 29 accredited Council of Social Work Education programs reported that alcohol and other drug-related content was insufficiently integrated into their social work programs, particularly the foundational curriculum. Substance use disorders and social work in Florida. Let's take a moment to discuss this. The large scale and high complexity of the issue makes social work especially crucial in this time of crisis. Our governor, DeSantis, recently declared a state of emergency in response to the opioid epidemic. With this crisis, there is a critical demand for social workers who are skilled in working with substance use disorders. Let's look at how our universities are educating our students. Throughout the state of Florida, Florida BSWs, if you can see in this graph, only 23.7% of them are receiving any education on the topic of substance use disorders. 76.3%, nothing. So, across the state, there are 6 electives at the BSW level that focus the entire course on substance use. Some are specific to the degree program, while others are cross-listed between the 2 degrees. And then there are 9 syllabi at the BSW level that have substance use disorder and relevant treatments covered in a portion of the classes. As you can see, this is problematic. Let's look at the MSW substance use disorder education. 28% do receive some sort of education on substance use disorders. 72%, nothing. So there are 10 electives at the MSW level that focus the entire course on substance use. Some are specific for the degree program, while a few are cross-listed between the 2 degrees. And there are 14 syllabi at the MSW level that have substance use disorder and relevant treatments covered in a portion of the courses. So the curriculum that we have been tasked to develop will be relevant to both BSW students and MSW students. The basic requirements for the new substance use disorder curriculum that we are developing includes 15 key content areas. So FSU and the Florida Consortium universities will be able to integrate content areas from this curriculum into our core courses, in addition to developing electives specifically dedicated to substance use disorders. In the field, recruitment continues to be a significant issue for many substance use disorder treatment facilities. According to survey respondents, facilities primarily used web-based classified advertisements in order to recruit new staff, and almost half of the facilities have difficulty filling those open positions, mostly due to an insufficient number of applicants who meet minimum qualifications. Through interviews, clinical directors emphasize the positive effects that developing relationships with colleges and universities can have on recruiting qualified individuals. Now let's briefly look at the NASW standards. These, for social work practice with clients with substance use disorders, were developed to broadly define the scope of services that social workers shall provide to clients with substance use disorders that clients and their families should expect, and that program administrators should support. What are the anticipated workforce development needs in the next 5 years? Well, applicants for open positions in substance use treatment facilities need to be better qualified. Just having an MSW is not enough. Clinical directors reported that their facilities face significant challenges in filling open positions, once again due to lack of qualified applicants. And the workforce must be diversified. The current workforce is predominantly white, female, over the age of 45. Younger professionals from diverse racial ethnic backgrounds who are able to work in integrated settings will be needed. So let's very briefly look at, to finish this section out, at the 6 megatrends that are going to affect substance use treatment workforce in the next 5 years. Of course, this is just a projection. We know macro level changes to healthcare and treatment delivery are going to change. A push for enhanced pre-service training, professional development, and uniform credentialing for those who wish to work in social work within the realm of substance use disorders. Increased use of evidence-based and recovery-oriented methods of substance use disorder treatment targeted for a changing client population and emerging drugs of use. Workforce recruitment and retention efforts. The recognition of substance use disorders as a valid health issue. And an implementation and use of health information technology. Part 2 is entitled, What is Addiction? What are substance use disorders? And what is meant by substance use and misuse? First, let's look at definitions. Let me read to you now the APA definition of addiction. It is a complex condition, a brain disease that is manifested by compulsive substance use despite harmful consequence. People with addiction, otherwise known as a severe substance use disorder, have an intense focus on using a certain substance, such as alcohol or drugs, to the point that it takes over their lives. ASAM's definition is very similar. Addiction is a treatable, chronic medical illness involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic illnesses or other chronic diseases. And lastly, the most important one to us as social workers, the DSM-5. Note that the word addiction is not applied as a diagnostic term in this classification, although it is in common usage in many countries to describe severe problems that are related to compulsive and habitual use of substances. So the more neutral term, substance use disorder, is used to describe the wide range of the disorder, from a mild form to a severe state of chronically relapsing compulsive drug taking. Some clinicians will choose to use the word addiction to describe more extreme presentations, but the word is omitted from the official DSM-5 substance use disorder diagnostic terminology because of its uncertain definition and its potentially negative connotation. So the scope and depth of substance use in the lives of those served by social workers. How is this going to affect us? Well, let's give a sampling of who we're going to be dealing with. Neglected children, couples dealing with marital dissolution and child custody disputes, adolescents experiencing school performance problems and teen onset of conduct disorders, older adults dealing with chronic pain issues, prison inmates, persons with HIV/AIDS, members of the homeless population, employees experiencing lost worker productivity, and more. Can you name some? We need to be informed. Why? Because we have to work holistically with our clients and synthesize knowledge from the field of substance use disorders and behavioral health. Remember, the world of addiction is always evolving. Our challenge is to reshape the public view of addiction. In so doing, we'll be able to help advance scientific knowledge in order to better treat our clients. How? By bringing about changes in policy. Social work practice is in a unique position to influence the delivery of services by addressing the acute and chronic needs of clients with substance use disorders. How? By developing and applying evidence-based approaches, incorporating established interventions and evolving techniques that are based on research findings, and also by improving treatment services for clients and their families. And also by providing social work students with the knowledge and ability to work with clients in order to develop effective treatment plans. Briefly, let's talk about the language of addiction. Remember, words have power. Why are words important? Think about it for a moment. And what are the messages beyond those words? Well, traditional behavioral health terms often communicate stigmatizing or demoralizing messages regarding persons in recovery. Strengths-based, recovery-focused alternative terms should be used in both written and verbal communications. Microaggressions are defined as subtle blows delivered incessantly, resulting in small wounds. They result when members of privileged groups, however they might be defined at any one instance, exert their power over the less privileged. And stereotypes continue to be a potent force in the formulation of public policy and perpetuate shameless persecution by our criminal justice system. Let's do our best to use person-first language. This is neither stigmatizing nor objectifying. It's used to acknowledge that the disability is not as important as the person's individuality and humanity. For example, a person with a substance use disorder should be used as opposed to an addict. Now, there are exceptions to first-person language because some people prefer to be called a certain way, especially in 12-step programs. You'll hear, my name's Jane and I'm an alcoholic. So those traditions have been going on since the 30s. They like that, they prefer that, so of course we're going to honor that. Dispelling negative bias. Treatment professionals and healthcare professionals and the general public continue to perpetuate negative bias with terms such as substance abuser, alcoholic, and addict. Let's be a part of the change. Let's say instead, a person with a substance use disorder, a person with an alcohol use disorder, a person with an opioid use disorder. And I just wanted to point this out too. Isn't it interesting that these terms are even strength-based? We're going to use recurrence of use instead of relapse. We're going to use medication-assisted recovery as opposed to medication-assisted treatment. Okay, social workers treating persons with substance use disorder need to be able to recognize intoxication and withdrawal syndromes for the major psychoactive substances. So we have decided to present these kind of treatment considerations for you. These are tailored specifically to social workers. So, know of the two major syndromes. All right, so you need to be familiar with the signs and symptoms of intoxication and withdrawal from the major substances used in substance use disorders. And let me give you some general rules of these two phenomena. There's a seesaw effect, and it exists between intoxication and withdrawal stages of substance use. Combining similar types of substances can increase both intoxication effects and severity of withdrawal. So, for example, two stimulants, say they're using cocaine and methamphetamine. Combining unlike substances can also complicate assessments of both intoxication and withdrawal. Say, let's use cocaine again with a CNS depressant with, or a CNS stimulant with a depressant like alcohol. And all withdrawal symptoms are stressful, but only certain substances have truly serious withdrawal effects. Social work treatment includes vigilance for symptoms that may suggest a need for medical interventions in both intoxication states and in withdrawal states. And we're going to talk about those now. So, the major types of substances we're going to talk about, and these are all psychoactive substances: CNS depressants, CNS stimulants, hallucinogens, atypical synthetic drugs, cannabinoids. And then this is how we're going to go through this section. Each substance will be examined first in its intoxication stage, second in its withdrawal stage, and third with treatment recommendations, hand-tailored to speak to social workers. All right, so the depressants are first. These are things like alcohol, benzodiazepines. Now these include both tranquilizers and sedative hypnotics, such as Xanax and Valium. Barbiturates, opioids, things such as heroin, morphine, other synthetic opiates such as oxycodone, hydrocodone, fentanyl, and inhalant substances. These are petroleum-based paints, distilled solvents and fuels, and spray can propellants. First off, alcohol use and alcohol intoxication. Okay, so alcohol has complex effects on the central nervous system. Alcohol produces psychoactive effects at blood level concentrations of around 0.5, and most states now recognize 0.8 as the level at which a person is legally drunk. Unlike most substances that mimic a naturally occurring molecule in the brain, alcohol is absorbed into neural membranes and affects several neurotransmitter functions. Alcohol increases the effects of a neurotransmitter called GABA, which makes nerve cells less active and then accounts for some of the relaxation effect. And the rate at which alcohol is metabolized may be faster for persons with a history of heavy use. And I'm sorry for the typo in this second bullet. It should be effect, E. All right, signs and symptoms of alcohol intoxication: clumsy motor coordination, unsteady gait, slurred speech, dizziness, double vision, nystagmus. That's that jumpy back and forth movements of the eye. If you look up this way, you can kind of see the eyeball jumping around. A lot of police officers determine intoxication by examining nystagmus. Impaired judgment and impaired memory, delayed thought processes, confusion, difficulty in problem solving, increased impulsivity with decreased ability to inhibit impulses, and potentially increased aggression. What does withdrawal look like? Well, among all the substances with serious effects, alcohol remains the most critical. People don't realize it, but you can die from alcohol withdrawal. That's why so often people on their way to rehab are given alcohol so that they can make it there safely and then begin their safe detoxification. Severe withdrawal from heavy drinking can be life-threatening, as just mentioned. Combine alcohol use along with benzodiazepines, bad combo, can extend the time frame for experiencing withdrawal symptoms and may also increase their severity. And serious alcohol withdrawal may call for medical attention at the first sign of seizures, delirium, or hallucinations. Tremors, sometimes these are very severe. They are called the shakes. Usually these appear, are you ready? 6 to 8 hours after the cessation of drinking. And then seizures come along. These can appear 10 to 12 hours after cessation of drinking. And tremors with hallucinations can occur any time within 72 hours of cessation, but can occur even with a week of cessation. So you see the importance of safe medical withdrawal from something that is life-threatening. That's why we always recommend for severe substance misusers a detox. And of course, delirium. Nausea, vomiting, sweating, facial flushing, anxiety, irritability, rapid heart rate, psychomotor agitation, and insomnia. What do? So treatment with clients who present with alcohol intoxication should determine the time of the outset of the drinking episode and extent of alcohol consumed in order to evaluate the likelihood of serious withdrawal effects. Client histories who have had serious withdrawal experiences should, of course, be assessed. And if client has been drinking heavy amounts for extended periods of time and has a history of serious withdrawals, then of course a medical referral is indicated. Social workers should always seek medical services for clients at the first sign of a serious tremor, mental confusion, hallucinations, visual or auditory hallucinations, that is, during withdrawal. This is above our scope of care dealing with these kind of withdrawal symptoms. A medical referral is also indicated if clients report concurrent, remember I mentioned before, benzodiazepines, bad combo. Same with opioids and barbiturate use mixed with the alcohol. And in the absence of indications for serious withdrawal effects, we can begin a non-medical detox. So non-medical detox calls for them to be in a quiet, low-lit environment, however not dark, plenty of liquids, preferably with electrolytes added, observing them often to make sure that they don't aspirate, and small amounts of mild food as the client requests. Let's look at drug use now. First off, we'll look at inhalant intoxication, the signs and symptoms. Dizziness, slurred speech, lethargy, increased impulsivity and aggressive behavior, tremors, depressed reflexes, possible stupor or even coma, double vision, nystagmus, odor of solvent fumes, impaired judgment, possible delirium, possible hallucinations or delusions, heart arrhythmias, bronchospasms. What does withdrawal look like? It's very generally similar to alcohol withdrawal if consumption has been repeated daily for extended periods of time. However, the typical use pattern is episodic and rarely involves withdrawal symptoms. Complications from extended use do include memory problems and dementia. What do we do as social workers? We should consider medical referrals for inhalant-using clients if they demonstrate serious physiological effects of either intoxication or withdrawal. One of the more likely problems during withdrawal from extended use is seizures. And of course, that's going to require medical management. Social workers should also remain vigilant about the extent of inhalant use in order to watch for risk of coma or unsafe behavior, such as walking into traffic or engaging in violent behavior. Residential treatment that includes detox may be the best option for clients with heavy inhalant use. Moving right along, benzodiazepines and barbiturates. Remember, these are just as dangerous as alcohol. As a matter of fact, the withdrawals are very similar. This class of drug affects the GABA system, just like alcohol. This class of drug has powerful tolerance and physical dependence characteristics. Combined with alcohol, they're potentiated, meaning the potency is increased. They produce a general sense of relaxation more than that euphoric effect. And users sometimes also use stimulant drugs with these CNS depressants or use marijuana in order to additionally relax. What are the symptoms? Slurred speech, impaired physical coordination, unsteady gait, impaired thinking with impairment in memory and in concentration or attention, possible stupor or even coma, nystagmus, drowsiness, increased impulsivity, and possible aggression. What does the withdrawal look like for this class of drugs? Increased irritability, agitation, anxiety, nausea, vomiting, tremors, sweating, possible seizures. Though rare, hallucinations or disturbing illusions. Social workers need to seek medical consultation on clients who exhibit benzo or barbiturate withdrawal. Above our pay grade. All right, and apart from close monitoring, what do we need to do? We need to just watch for those serious risks, health risks during withdrawal. Our interventions generally include teaching family members or significant others to closely observe the clients during their days of detoxification. Yeah, a non-medical detox can be used as long as there's close monitoring for symptoms that might require medical interventions. Again, they should be placed in quiet, non-threatening environments, and we should pretty much just leave them alone. If they ask for food, make sure it's bland with moderate amounts of liquid. These help in the detoxification process. Now this I thought was interesting. I felt really strongly about putting this slide in. It talks about drugs, particularly opioids here in Florida. Opioids, remember, are a case of drugs that include heroin, fentanyl, pain relievers available legally by prescription. There are many of them. They're marketed in many different ways. Oxycodone, hydrocodone, codeine, morphine, so many others. But NIDA reports that every day 130 people in the US die after overdosing on opioids. I actually think that's a conservative number. The misuse of the addiction to opioids, including pain relievers, heroin, and synthetic opioids such as fentanyl, is a serious national crisis, and it affects public health, large scale, as well as social and economic welfare. In Florida, the opioid-related overdose death was 14.4 per 100,000 in our population, and that was in 2016. And the rate of opioid prescription per 100 people was 62.8%, or 62.8 people. So let's talk about opioids. Again, we should all be well versed in this drug because we're in the throes of this epidemic right now. Various opioid preparations are used in among people with substance use disorders. Remember, they're marketed in many different ways. And these market conditions affect use patterns and the strength of the opioids. Opioids affect the brain's opioid receptor sites, and this is involved in analgesia, or pain relief. Opioid molecules mimic the brain's endorphins, which mediate the pain and account for the natural highs. A good example would be from those highs you get from aerobic activities like running. The use of opioids commonly cause constipation, and this is no joke. This needs to be assessed and treated as part of the substance use disorder treatment episode. And opioids also interact with the dopamine system, which accounts for much of its euphoric effect. Opioid overdose can result in respiratory depression to the point of death. Okay, opioid intoxication signs and symptoms. We're going to be doing assessments. We're going to explore concurrent use of benzos or alcohol. Why? Because these are very common and they very much complicate intoxication effects. Altered mood, pinpoint pupils, slowed bodily motions, otherwise known as psychomotor retardation, slowed respiratory rate, drowsiness, slurred speech, impaired memory and attention, less responsive thinking, and impaired problem solving. With overdose, complete respiratory failure can occur. The withdrawals are so uncomfortable, but rarely will you die from opioid withdrawal. They're just so painful. While the medical risks from opioid withdrawal are minimal, clients often feel extremely disturbed by the withdrawal and may desperately seek drugs to relieve the discomfort. Withdrawal can begin 6 to 8 hours for some opioids and more than a day for others, like methadone. Depressed or dysphoric mood, nausea, vomiting, muscle aches, tearing, runny nose, pupillary dilation, sweating, diarrhea, fever, frequent yawning, and insomnia. What do? Well, the standard care these days, thank goodness, is to administer naloxone, otherwise known as Narcan. And this actually reverses the opioid intoxication. Social work interventions with clients intoxicated on opioids should include assessing clients about their withdrawal history and their experiences. While medical intervention is not critical, some clients will benefit from medications to moderate some of the withdrawal symptoms, and in these cases, a medical referral may be indicated. Clients need constant support and constant encouragement during the withdrawal process. Why? Because they may flee treatment in order to avoid completing detox. That's how painful it is. So our job should be to assure clients that in spite of feeling awful, terrible, they will survive this withdrawal. And I want everyone to hear this one too. Depending on their opioid history, clients may be candidates for rapid referral, because usually these kind of referrals are not rapid, to medically assisted treatments, otherwise known as MATs. These can either be used for gradual detox or maintenance, so they get started during the withdrawal process, and then a prescription is written for maintenance, and it completely eliminates withdrawal. Next we're moving on to CNS stimulants. Okay, so this class of drugs, includes many different preparations: cocaine, amphetamines, dextroamphetamines, methylphenidate, methamphetamine, other prescribed ADHD medications, substituted amphetamines in some of the club drugs like MDMA, ecstasy, caffeine, and yes, nicotine. Oh, and cat. You may have been reading a little bit about that lately. Okay, so these are stimulants. Stimulants represent represent another high-risk category of drugs, as they can easily lead to death. especially when people have underlying health conditions or when large amounts are taken. Also, stimulants are often taken with CNS depressants, and the combined contradictory efforts can increase health risks. And stimulants increase the natural neurotransmitter, norepinephrine, you may know that as adrenaline, as well as the dopamine and serotonin systems, so users get euphoria, high energy, and excited thinking. So here are some of the signs: a racing heart, tachycardia, or a slowed down heart, bradycardia. Pupil dilation, sweating, nausea, vomiting, psychomotor agitation, this restlessness, this overactivity, or psychomotor retardation, slowed down activities. Euphoria, confusion, seizures, possible coma, muscle weakness, uncontrollable contractions of the muscles, respiratory depression, and appetite loss. Many clients who misuse cocaine are underweight. So here are the withdrawals, some more withdrawal symptoms: tremors, depressed mood, lethargy, nightmares, headaches, heavy sweating, muscle cramps, stomach cramps, intensive hunger, and intense craving, particularly noted in cocaine withdrawal. What do? You know, heavy use of stimulants don't really have a drug that we can help them with, you know, help to safely detoxify. But heavy use of stimulants, just know they can result in heart attacks, in strokes, in seriously high blood pressure. So medical evaluation may be indicated for heavy users. Generally, they just want to sleep when they're coming down. Cocaine, when snorted, also causes damage to the nasal tissues and even a perforation of the septa between the nostrils. And treatment for intoxicated clients should include vigilance for major health problems. This is what we're supposed to be looking for. And medical referrals may be indicated if they do have those major health problems and they are misusing cocaine or any of the stimulants, particularly if there's a history of serious withdrawal or intoxication effects. Psychiatric assessment may be indicated among users who develop severe depressive symptoms upon withdrawal. You know, the withdrawal symptoms for some of these CNS, and especially methamphetamine and cocaine, are the depression can become suicidal and very dangerous. All right, social work treatment continued for this. Inpatient treatment might be the safest approach to detox persons with long-term and heavy stimulant intoxication. Why? Well, the controlled environment keeps users from acting on their cravings. Social workers can guide family members of others who will be with the clients to reassure them that they can successfully detox and that the severity of the symptoms will decrease in a few hours or a few days, as mentioned, with a good amount of sleep. Short to medium-term residential treatment may also be the preferred post-detox treatment until clients can maintain a reasonable period of drug-free status. Remember, those cravings grab you and unfortunately cause recurrence of use more often than not with some of these CNS drugs, okay? Hallucinogens, these include PCP, mescaline, LSD, psilocybin, and ketamine. Often used along with cannabinoids, and this complicates the intoxication presentation. So again, these are when two drugs are being used at once, it becomes tricky in the assessment process and the treatment process. Most hallucinogens activate the serotonin system, while some, specifically ketamine and PCP, affect the glutamate and dopamine systems. Tolerance develops rapidly, only after, say, 3 or 4 days of continuous use. Others become psychologically dependent on psychedelic experiences. So here's the signs and symptoms: distorted, exaggerated, and even violent reactions, uncommunicative behavior, experience increased bodily warmth, depersonalization, pupil dilation, a sensation of floating, distorted perceptions of time and space, nystagmus again, both vertical and horizontal, ataxia, this is when you have difficulty coordinating, especially with walking, head rolling, muscle rigidity, stroking, vomiting, chanted and repetitive speech, and of course, sweating. The withdrawals, there's no direct pharmacological withdrawal syndrome as compared to the previously mentioned drugs. In the absence of hallucinogen use, users may experience flashbacks. And in these, there will be visual distortions, hearing sounds or voices that are not there, flashes of color, halo effects around objects in their visual field, suicidal behavior, sometimes due to distorted reality perceptions, panic reactions, and fears of insanity, bad trips. Social work treatment. So here we go. It's been associated with psychotic disorders. So we as social workers need to be aware of that. We need to assess client family history for psychotic disorders. Persons with psychotic disorders might seek out hallucinogens or might have the disorders triggered or exacerbated by hallucinogen use. The psychiatric dimensions of hallucinogen use may complicate social work interventions. Next up, cannabinoid intoxication, signs and symptoms. Remember, cannabinoid intoxication is complex, as plants can contain over 400 chemicals, over 50 of which are related to the active marijuana ingredient THC. THC binds to the cannabinoid receptor sites in the limbic system, particularly the hippocampus. This is the memory storing, the memory retrieving system, and the cerebellum. It is lipophilic, meaning it is stored in body fats, and thus lasts much longer than water-soluble drugs. And motor and cognitive effects can last up to 12 hours, depending on the concentration of THC in the product. What are the signs and symptoms? Well, the old red eye, caused by a dilation of blood vessels in the eye, munchies, increased appetite, dry mouth, tachycardia, this is a racing heart rate, depersonalization or derealization, impaired motor skills that last much longer than the high itself, increased sensitivity to colors and light, changed perception of time, heightened sensitivity to color and other stimuli, possible paranoia, decreased motivation, the couch potato syndrome, and cannabinoid withdrawal. Withdrawal from cannabis is not like other drugs. It's not an immediate effect. Cannabinoid withdrawal can show up 2 weeks later. And it shows up in the form of increased irritability, craving, impaired reaction times, diminished concentration, nervousness, anxiety, insomnia, headaches, restlessness, anorexia, stomach pains. It could actually even include mild nausea and rarely persistent vomiting, and possible tremors and sweating. What do we do with cannabis users, misusers who are entering recovery? Rarely do they get treated in residential treatment settings. However, it's rare for us to encounter clients who use only cannabis. So it's the combination of the other drugs that might suggest a need for residential treatment if the person cannot maintain a reasonable period of drug-free status. It is an increasingly difficult use pattern to treat due to increased legalization and medical use of cannabis. However, risks from severe intoxication or withdrawal are low, and thus treatment is rarely punctuated by serious consequences apart from legal problems. And let's talk now briefly about new designer drugs. They're coming up every day. We learn of something new. There's new drug trends. Think about 10 years ago, some of those trends that were so huge then are gone now. So new drugs are entering the scene. you know, with the times. Now we're hearing a lot of bath salts. Well, they've been around for a while, but I've been hearing a lot about kratom lately. Bath salts can contain any number of ingredients and varying strengths. And kratom appears to be something like a milder opioid-like substance, but with less worrisome withdrawal effects. Some clients are using it almost as if they're using buprenorphine, like as a hedge between withdrawals and craving. On interviewing clients reporting these kinds of drugs, social workers might seek medical consultation in finalizing any treatment recommendations or plans. All right, next we're going to talk about law enforcement or the legal classifications. It's important that we know about this too, especially with the hope that we will be working even more closely with law enforcement when we're dealing with the substance use population. And I would be remiss if I didn't talk about the Marchman Act. The Marchman Act generally is 5 days of involuntary treatment. And the reason why it's 5 days as opposed to our Baker Act 3 days is because we just talked about sometimes the withdrawals don't start until a good amount of time later. Now, there's a lot of controversy about the legal classifications right now because, especially mind-blowingly, marijuana is still considered a Schedule I drug. I keep hearing that it's going to change, but why it has taken so long, it's just ridiculous. Let's read the definition for Schedule I drugs. They have no currently accepted medical use and a high potential for misuse. So right along with marijuana are drugs like heroin, LSD, and hallucinogens. Schedule II drugs have a high potential for misuse, with use potentially leading to severe psychological or physical dependence. These drugs are also considered dangerous. Vicodin, cocaine, methamphetamine, methadone, Dilaudid, Demerol, OxyContin, fentanyl, Dexedrine, Adderall, and Ritalin. Right, and also a lot of the sentencing guidelines are related directly to the schedule. Schedule III drugs have a moderate to low potential for misuse for physical and psychological dependence. So these are products that contain less than 90 milligrams of codeine per dosage unit. So take, for example, Tylenol with codeine. Also includes ketamine, anabolic steroids, and testosterone. Schedule IV, these are the drugs that have low potential for misuse. I see Xanax in there. And low dependence. Soma, Darvon, Darvocet, Valium, Ativan. Okay, yeah. And Schedule V, these drugs consist of preparations containing limited quantities of certain narcotics. So they're generally used for like anti-diarrheal, anti-tussive and analgesic purposes, cough preparations, etc. You know, Robitussin is on that list, as is Lamotil and Lyrica. Okay, here we go into the DSM-5. What does the DSM-5 say? Well, it's all these new categories, but this is how they've chosen to present substance use disorders. It's substance-related and addictive disorders. So these are the classifications. Here are the subcategories: substance use disorders, substance medication-induced, substance medication-induced disorders. That little dash shouldn't be there. And non-substance related disorders. Okay? So just to be clear, I want to let you know there are 3 subcategories. So, substance use disorders. These are drugs that are taken in excess. So there's a direct activation of the brain reward system. It reinforces behaviors, causes the production of memories. Pharmacological mechanisms produce varying rewards. Drugs typically activate the system and produce feelings of pleasure, often referred to as a high. And individuals with lower levels of self-control, which may reflect impairments of brain inhibitory mechanisms, may be particularly predisposed to develop substance use disorders. All right, so here is the list of substance use disorder criteria. Taking the substance in larger amounts or for longer than you're meant to. Wanting to cut down or stop using the substance but not managing to. Spending a lot of time getting, using, or recovering from use of the substance. Cravings and urges to use the substance. Not managing to do what you should at work, at home, or school because of substance use. Continuing to use even when it causes problems in relationships. Giving up important social, occupational, or recreational activities because of substance use. Using substances again and again, even when it puts you in danger. Continuing to use even when you know you have a physical or psychological problem that could have been caused or made worse by the substance. Needing more of the substance to get the effect that you want. So building up a tolerance. Those are the criteria. Now, after we establish how many criteria there are for this particular client, we will figure out what the level of severity is. If there are 2 or 3 symptoms off of that previous list, that indicates a mild substance use disorder. If 4 or 5 of those symptoms have been checked off, that's a moderate substance use disorder. And 6 or more symptoms indicates a severe substance use disorder, okay? Previously known as addiction or chemical dependency, all right? Those words are gone. We're trying to get rid of them. Let's use severe substance use disorder when we're talking about somebody with those extreme problems. Okay, then there's substance medication-induced disorders. So substance medication-induced mental disorders are mental problems that people develop who did not have mental health problems before they used the substances, right? So this, in other words, the substances bring on a mental health disorder. So here are some examples. A substance-induced psychotic disorder, a substance-induced bipolar and related disorders, substance-induced depressive disorders, substance-induced anxiety disorders, substance-induced obsessive-compulsive and related disorders, substance-induced sleep disorders, substance-induced sexual dysfunctions, substance-induced delirium, substance-induced neurocognitive disorders. And then we have the last thing that I'd like to discuss, those non-related disorders. So in addition to the substance-related disorders, the DSM-5 includes gambling disorder. Gambling disorder was categorized as a behavioral addiction. And according to the APA, this change reflects the increasing and consistent evidence that some behaviors, such as gambling, activate the brain reward system with effects similar to those of drugs of abuse or misuse, and that gambling disorder symptoms resemble substance use disorders to a certain extent. This category addresses other excessive behavioral patterns. However, there is still insufficient peer review evidence to establish the diagnostic criteria and course descriptions needed to identify other behaviors as mental disorders. Perhaps and hopefully we'll see them in the DSM-6. All right, now we're going to try and explain addiction. So we have all of these models: the moral, psychological, family, disease, public health, developmental models, biological models, and we also have alternative explanations. Remember, it is an inexact science. Numerous theories and models exist. There are so many perspectives. Some are moralistic, some are scientific, some are oppositional. But these models do influence policy. All right, and I just mentioned all of those. We'll be discussing them. And just keep in mind, too, that social, religious, and legal forces also interplay to shape what society's perception of substance use is all about. Models do explain and provide frameworks for understanding human behavior. There are many different models that attempt to explain the development and maintenance of a substance use disorder. Remember, not one model explains all or even most of the development of the addiction or the addictive behavior. Person environment, you all know about this. It provides the best mechanism for an understanding of addiction. And this perspective is based on the notion that an individual and his or her behavior cannot be understood adequately without consideration of the various aspects of that person's environment. Here's some of the theories. Let's go through these rather quickly. We have the moral model. It's discredited by modern scholars, but this is the model that says addiction is a product of sin and moral weakness. It's important to note because unfortunately it still informs most of our public policy. Psychological models. These are the cognitive behavioral models, learning, psychodynamic, and personality models. So let's first talk about cognitive behavioral. Humans ingest substances to experience variety. They desire to experience pleasure. This sets the stage for addiction because with time, the brain adapts to the presence of the substance, and removal of the substance leads to negative symptoms, withdrawals, and to avoid those symptoms, negative reinforcement happens. They take actions to avoid the unpleasant stimuli, and they recur their use. The learning model. This says this is when substance use results in a decrease in psychological states. You use, it relieves your anxiety, your stress, your tension, and that reinforces the use. It feels good, do it again. But this also says what's learned can be unlearned. So the learning model implies that something can also be relearned. So for example, forget about abstinence, you can learn to control your use. So the psychodynamic model, very briefly, it still serves to guide a substantial portion of our clinical practice, and it focuses on insight into problems. But it does not give enough attention to the addictive power of the substances. And the personality model states, there's so many personality factors common to substance misusers, for example, impulsivity, risk-taking, and sensation-taking. They could be predictors. Family models. Family-based approaches assist in understanding the development of substance use disorders. Look at the family. All right, behavioral models. So members of the family reinforce the behavior of the substance misuser. Family systems models says that family roles actually become threatened by shifting familiar patterns once the misuser enters recovery. And then the family disease model concentrates on genetic and environmental influences that cause the family entity to all have the disease and therefore all must enter recovery. The disease model is the chemical or biological issue that substance use disorders are primary, progressive, chronic, and if left untreated, fatal. And it's characterized by an obsession to use the drugs or drink, and it's environmental, genetic, and neurological sources of origin. It's chronic, incurable, and the best cure or the best source of treatment is abstinence. The public health model, quickly. It says addiction is not public, it's a private issue. It's a societal disease. And this is how it has everything to do with public education, laws, social taboos, societal norms and roles, prevents or encourage substance use or misuse. And this led to the rise of a lot of our public health organizations such as SAMHSA, WHO, the CDC, NIDA, and NIAAA. The developmental disorder understands factors that increase or decrease risk for the individual to use or misuse substances, and it recognizes the vulnerability varies across the lifespan, right? The prenatal through childhood or through early childhood, middle childhood, adolescence, late adolescence, early adulthood, the life stages of Erik Erikson, and people are more predisposed during certain times of their lives. Okay, and then the biological or genetic models. There's a strong association between genetic factors and substance use. Possibly an inherited metabolic defect may interact with environmental factors and eventually lead to addiction. There's no specific genetic marker that predisposes someone towards a substance use disorder. but some stats are that adopted children more closely remember their biological parents regarding alcohol use, and alcohol use disorder occurs more frequently in some families than others. Particularly interesting are the twin studies. Alcohol use disorder rates are higher in monozygotic twins than in dizygotic twins. And multi-causal models. No single model can adequately explain why some individuals become addicted and others do not. The motivation to use varies from person to person. And quickly, if you're interested, these are alternative explanations. These are out-of-the-box thinkers. Vinaigrette is the first one, where he just says, hey, addiction is a lifestyle. It's a self-destructive one at that, but it's their choice. Let them live it. The same with the work of Peel. Addiction as a difference in values and priorities. You know, this is what they want to do. It's their right to do it. Why are we getting in their way? And last, the work of Shaler, where he sees addiction as a metaphorical disease. Also really interesting reading. Okay, next up, we are on part 3, screening, assessment, and diagnosis. And screening, just know, is a use of rapid assessment instruments and tools to determine the likelihood that an individual has or is at risk of developing a substance use disorder. It's often very informal in practice, and it's recommended to screen all clients, even those not receiving substance use disorder treatment, every visit. Assessment is more in-depth. It's a multi-stage process following screening. It's used to inform the treatment plan and determine whether the treatment plan is working. Assessment is a structured process which provides the opportunity to collect the following things: demographics, history, probable diagnosis. You know, you can identify a probable diagnosis, strengths and problem areas. What stage of change are they in? And diagnosis, of course, is part of the assessment process, and we utilize the DSM-5. In many cases, we will be finding co-occurring disorders. Here's a quick example assessment. What are you going to do? You're going to engage the client, identify contact collaterals, if appropriate and if permissible, screen for co-occurring disorders, including risk of harm to self and history of trauma, and determine the severity of the substance use disorder, determine the level of care, and then determine the diagnosis. So very quickly, I want to go through some of these tools. They'll be here for you. I've included the links. Many of these I've used, and I can say, thank goodness they're out there. So very briefly, let's talk about Assist. This was developed by who? It's free. Boom, there's the site. Espert, you've probably heard a lot about this in your classes because it can be adapted to any population, all right? But it's a preventative screening designed to be implemented in healthcare settings, any healthcare settings, by the way. Probably the last time you went to the doctor or the dentist, they did an Espert on you. It can also be used in mental health settings. It's used to identify alcohol or opioid use, and pretty much it sums it up: screening, brief intervention, and referral to treatment, Espert. All right, so there's an online version. By the way, you all can get an online certification too. Audit is also popular, and it's alcohol intake, alcohol potential dependence, and experience of alcohol-related harm. Can be self-administered. This one's free. BSTAD, this one is another one by NIDA. There's the website. Here's one. This one's TAPS 1 and TAPS 2. And why it combines, it's a brief assessment, and it's for commonly used substances, eliminating the need for multiple screening and lengthy tool assessments. And there's the tool. CAGE is another one that's still out there and used a lot, and it includes 5 questions. Have you ever felt like you ought to cut down? Have people annoyed you by criticizing your drinking? Have you felt bad or guilty about your drinking? Have you ever had a drink or used drugs first thing in the morning? And then you come up with your score. SASSY is another one that's widely used. Right? CRAFT, this one is I always found interesting. It highlights the words. Have you ever ridden in a car driven by someone who was high? Do you ever use alcohol or drugs to relax? Oh, to feel better about yourself. A, do you drink alone? F, do you forget things? F, do your family or friends tell you should cut back? T, have you ever gotten in trouble? DAST, here's another one. This one is 10 items. Have you ever used drugs other than those required for medical reasons? Do you use more than one drug at a time? Are you always able to stop using when you want to? Have you had blackouts or flashbacks? Do you ever feel bad or guilty after using? Does your spouse ever complain? Have you neglected your family? Have you engaged in illegal activities? Have you ever experienced withdrawal symptoms? Have you had medical problems as a result of your drug use? Again, and then the scoring is listed there. And I can't state enough how you've got to screen for comorbidities, because more often than not, they are people who have a substance use disorder are also living with mental health disorders. And also, don't forget physical health conditions as well are comorbid. This is when an individual struggles with more than one diagnosis, right? Could be chronic pain, tobacco use, mental illness, HIV. So they do have a screen for comorbidities. It's called the PRISM, and it's used for, look at the list: substance use, pathological gambling, primary and substance-induced moods, anxiety, eating disorders, personality disorders, attention deficit disorders. So I would really check some of these out when time allows, and also assess for cognitive functions. Quite often, substance use disorder has a very negative effect on cognitive functioning. It could be associated with neurophysiological and neuroanatomical changes, as well as cognitive impairment that can affect the quality of life, occupational functioning, and the ability to benefit from therapy. And also, neurocognitive assessment services are costly, and they're not widely available. So here's one called Brief. And lastly, we are at part 4. This is an overview of treatment, its modalities, and its major approaches. So first off, we have outpatient counseling. This is the gold standard. This is the mainstay of substance use treatment in the US. Then we have intensive outpatient, otherwise known as IOPs. These are used to treat substance use disorder where standard outpatient is seen as too risky. So IOPs meet approximately 4 times a week and include individual and group approaches. And more often than not, they're in the evening so that the person can still attend their jobs. Then there's residential treatment. This is different from inpatient care, however. Residential is usually a drug-free living environment that makes heavy use of group therapy aimed at preparing clients for longer-term and sustained outpatient counseling. And there's inpatient care. This hospital modality is reserved for inpatient medical management of withdrawal symptoms or substance use disorders that have acute psychiatric conditions. Then there's case management. Case managers are generally hold on. I can't see that corner word, and I want to make sure I get it right. Okay, yes. Case managers are generally not licensed treatment providers. They provide home visit to promote continued treatment participation, and they may help out with obtaining social and economic supports during recovery. MATs, we've heard a lot about this. MATs can involve a wide range of medications, either used to directly treat the substance use disorder symptoms or mental health systems that directly impact recovery. And also, in this day and age, we've got telephone therapy. It's becoming more and more popular. Cell phone apps as well. Gives a lot of room for two-way communication through messaging. And I think a lot of people like this too because of the anonymity of this approach. And telemedicine, and things like Zoom and using the cyber form for therapy, cyber therapy. But COVID-19 epidemic has led to an increased use of telemedicine as a way to bring treatment personnel and clients together for assessment and intervention services. And let's face it, it's inexpensive, and everybody has flexible time. Well, not everybody, but most people can be flexible with their time. All right, quickly, the levels of care and ASAM. So I'm about to list the levels of care, but I just wanted to let you know what they were about. We just wanted to let you know what they were about. The modalities of care are all often arranged hierarchically into levels of care. So the ASAM criteria set out 6 dimensions, and these were to be used in assessing and treatment needs. So the assessment along the 6 dimensions suggests the level of intensity and specific characteristics of a person's need for recovery. Here they are. First, acute intoxication and/or withdrawal potential. This includes exploring the client's current and past experiences. Then there are the biomedical conditions and complications. Client's physical condition and presence of complicating conditions like diabetes are explored. Emotional, behavior, cognitive conditions and complications. What is the readiness to change? Relapse, continued use or continued problem potential. And lastly, recovering living environment. So we generally use these, we think of these as a checklist of key factors when we're assessing what our clients' treatment needs are going to be. So of course, treatment is in stages. The stages of treatment for substance use disorders are based on where clients are in the disorder process. For example, a person who arrives at a treatment setting clearly heavily intoxicated will not be a candidate for outpatient counseling. On the other hand, a client who has completed residential treatment and IOP would likely be a candidate for outpatient counseling. They range from approaches to be used early in the process that are quite different from one might consider after a lengthy period of drug-free status. Now, let's talk about some basics in treatment thinking. These are just common practices that we wanted to review. So interviewing, the 3-stage interviewing model for social workers. These are just good interviewing skills for the screening and assessment stage, and also for coming up with a treatment plan. Exploration. This is when you establish a working relationship with the client. You identify with the client what their problems and concerns are. Then there's the clarification stage, where again, you come up with the problems, collaborating with the client. Even when substance use is known to be the central problem, you want them to be the one to define their problem and help them to prioritize the problems and then set their goals. And finally, action. Assist them in coming up with an action plan for each goal, work with them to accomplish the goal, and then terminate counseling when the goals are accomplished. The importance of documentation cannot be stressed enough. We need to ethically document our services rendered. We need to provide a permanent record of client service provision. There are lots of reasons for this. Continuity of care is one. We need to have a continuity of services too. Reviewing and amending treatment plans and tracking their progress, giving statistics. Quite often we're audited, and quality control comes in to make sure that our agencies are in adherence. Insurance reimbursement purposes. Sometimes if we don't record what we're doing, we're not going to get paid. And consumer sessions. You know, we need to document what transpires in our sessions with our clients so that the next social worker or the doctor or the nurses can read what we wrote. Always remember to keep records secure. Confidentiality is sacred. We need to honor it. All right. Evidence supports, too, that non-technical aspects of therapeutic work have been shown to be associated with successful outcomes, and they're important for producing the benefits of psychotherapy. Things like the relationship between the two of you. What are the client's expectations of treatment? That's going to influence. The attributes of the social workers and the client. Right? What are their strengths? That's going to play into whether or not the encounter is successful. Do they have good support systems? How about the institutional and organization conditions that we're practicing under? And strategic actions that we are using. Are we up to date on empirically sound approaches? Are we adept at implementing them? I love this quote by Carl Rogers. In my early profession years, I was asking the question, how can I treat or cure or change that person? Now I would rephrase the question or phrase the question in this way. How can I provide a relationship with this person that they may use for their own personal growth? And here are the stages of change by Prochaska and DiClemente. It's really important to ask the right questions in order to elicit what the stage of change of the client is. Pre-contemplation, contemplation, preparation, action, maintenance, relapse. All right, motivational interviewing. Let's talk about it. Of course, it's built around ideas. You are to tap into change talk. The spirit of motivational interviewing is that motivation to change is elicited from the client. It's not imposed from without. It's the client's task, not the counselor's, to resolve the ambivalence. We don't use persuasion. We roll with the punches here. We roll with their resistance. Our style should be quiet and a listening, and also remember that we're going to constantly be evaluating their readiness to change. Oh, and the therapeutic relationship is more like a partnership or a companionship. We are not the experts. So express empathy by reflective listening. To me, that's the most useful technique in motivational interviewing, reflective listening. Develop discrepancies. That's another important one, however, between the client's goals or values and what their current behaviors are, and then talk about that discrepancy. Always avoid argument and confrontation, and adjust to their resistance. Support their self-efficacy and their optimism. So MI is something that can set the stage for any form of substance use disorder treatment. It provides the right emotional tone for challenges of treatment and recovery. And while it's not a treatment, it's more of a technique. It can be incorporated into any of the techniques. Let's look at one of those. Group therapy. Just like motivational interviewing, group therapies can be used across a wide spectrum of treatment modalities. Group therapy is employed in cognitive behavioral therapy, contingency management, mindfulness, and in harm reduction approaches, all of which we're going to talk about briefly. And the style or form taken is going to depend on the therapeutic approach and what stage the client's in, stage of change. And effectiveness is in part due to their affiliation with the other participants who they derive support from, they share their experiences with, and they encounter these valid challenges together. So in most practice settings, they will have had individual therapy first before they go into group. And just know treatment groups have their own structure and rules. Many groups for substance use disorder treatment basically fall back on the 12-step meeting model, but the social worker can be there in a more of facilitating, organizing role. And if you don't know the work of Irving Yalom, then check it out. He's the master of group. All right, in many settings, let me see, I moved my, yeah, they're used to improve, in many settings, group approaches really help the client to incorporate coping mechanisms, and clients who are unable to sustain periods of absence maybe might not be right for group therapy. Let's face it, attending intoxicated is not okay. It could have a damaging effect on the other participants, and it could undercut your credibility. And groups are well suited to address multiple co-occurring disorders. There's a really great program called Seeking Safety, which is a women's group, and it incorporates PTSD and substance use disorder themes. And social workers, as usual, need to be sensitive to cultural, ethnic, racial, and gender considerations. Sometimes gender-specific groups are known to be better. They're actually a standard of care in many places. And the reason why is, let's face it, a lot of women have abuse experiences. The rate of sexual abuse is very high in those with substance use disorders, and they might feel more comfortable sharing with other women. Their trust levels and adherence is greater when they're in groups with other women. Next up, CBT. This approach was originally developed for depression and anxiety, but it has successfully been adapted to work with substance use disorders. Let's look at this first. Thoughts create feelings. Feelings create behaviors. Behaviors reinforce thoughts. CBT 101 right there. So it helps identify, evaluate, and respond to their dysfunctional thoughts or beliefs. And there's a bunch of techniques that we're going to talk about. But the idea is that automatic thoughts generate emotions, and emotions drive behaviors. And in this case, their substance use. So by helping people change their automatic thoughts, they reduce the negative emotions, and this reduces their drive to use substances. Always, there are homework assignments in CBT, and it could be any assignment that could monitor and assist the client in seeing the connections between thoughts, feelings, and behaviors. So, social workers need to help clients find out what those automatic thoughts are that affect their emotions and actions. For example, an individual might overgeneralize from a negative experience or might catastrophize an event. In this case, the person takes one incident and sees it as this lifelong disaster, which results in anger, depression, and despair. And then this set of emotions is the primary stimulus for moving them to use substances in order to submerge those negative feelings. All right, so here are some of the techniques. Cognitive restructuring. They identify the thoughts and then reframe them in a more positive light. Guided discoveries. They're going to answer questions designed to challenge their beliefs and broaden their thinking and see things in a new way. Journaling and thought records always work, where they record the positive thoughts and the new behaviors that were put in practice since the last session. Relaxation and reduction techniques, deep breathing, muscle relaxation, imaging exercises, mindfulness exercises in order to lower stress, and role playing. I love role playing. Clients are going to play out possible scenarios of difficult situations in order to improve their problem solving skill and gain the confidence in practicing their social skills. Contingency management is another one. This is interesting. It uses motivational incentives or tangible reinforcers such as vouchers or gifts or goods or privileges in order to achieve concrete targeted behaviors, or when they do. So it acknowledges an association between a voluntary behavior and a consequence, all right? And of course, the nature of the consequence will impact if the behavior happens again. So the target behavior is first identified, then tangible reinforcers are provided, and when the targeted behavior doesn't occur, the reinforcers are withheld. So it's all about incentives, and it marks accomplishments, acknowledges achievements. You might remember from 12-step programs the chips or the medallions they get at birthday meetings. Reinforcers. These are more like they give. This reminds me of almost training. I'm training a puppy right now, so it's almost like you give them reinforcers after baby steps, and then this gradually increases the occurrence of desired behaviors. And then give out incentives frequently for small, manageable instances of change. And this is called the fishbowl, where you actually have a fishbowl and you draw from the bowl. Say, for example, you have a drug-free urine. You get two draws for the second drug-free urine. Now, you lose the opportunity to draw if you come up with a positive drug screen, but you're not, chided or anything like that. It's just, okay, well, you don't get one this week. And then when they're drug-free again, you start over at the beginning with one draw, and the prizes are also received right on the spot, and the rewards are gradually removed if clients leave treatment and return to life without the contingencies. But the expectation is that the rewards of responsible living will be more powerful over time and thus reduce the need for substances. Let's look at mindfulness-based interventions. This is emerging. It's derived from Eastern religion and spiritual traditions in Western monasticism. Mindfulness is not wedded to any one religion, and it teaches clients how to remove the mind from its obsessive focus on emotional states and beliefs. And to do this, clients learn to focus only on breathing, counting respirations, or repeating a simple phrase, otherwise known as a mantra. And by placing the mind on these simple biological processes and repetitions, the mind is pried loose from its locked-in focus, worries, obsessions. So mindfulness can be practiced in group or individual settings, and it's particularly effective in preventing depression, relapse, and next up we have 12-step facilitation. So this is very commonly used. It's used very much in treatment centers. Oh, sorry, I didn't mean to go so quickly. Well, yeah, yes, I did. Okay, so the 12-step approaches are limited, but they're still emerging. The research is limited, but there's still emerging studies coming out. But the safest use of 12-step approaches is with clients who have completed acute care and they maintain abstinence for a sustained period of time. So they're in the maintenance phase right now. So the central assumptions of 12-step are that addiction is a multifaceted disease. It's consistent with 12-step mutual help organization is the fact that, it's emotional. In some cases, spiritual growth is critical. They need to be going to 12-step. And so your job as the therapist is to sort of just talk to them about their 12-step experiences, keep them accountable. If they're engaging in the 12-step program, they might want to share with you what they're learning and what they've accomplished. And you, again, as the clinical provider, can help them address any obstacles that they have with their 12-step work. And lastly, harm reduction. All right, harm reduction is very controversial and it's very political, and it does include MATs. So harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice, built on a belief in and respect for the rights of people who use drugs, okay? It accepts, for better or for worse, that licit and illicit drug use is just part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condemn them. Self-determination plays a big role in this. It understands that drug use is a complex, multifaceted phenomenon. It has a continuum of behaviors from severe abuse to total abstinence, and it acknowledges that some ways of using drugs are clearly safer than other ways. It calls for non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assess them in reducing harm. Ensures that drug users and those with a history of drug use have a real voice in the creation of the programs and policies that are designed to serve them. It affirms drug users themselves as the primary agents of reducing the harm of their drug use, and it seeks to empower users to share information and support each other, which meets their actual conditions of use. It recognizes the reality of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other inequalities that affect both people's vulnerability to and capacity for dealing with drug-related harm. It does not attempt to minimize or ignore the real and tragic harm and danger associated with licit and illicit drugs. And the main approach in harm reduction is MAT. And we've talked about MAT. It's when clients demonstrate no or very limited ability to achieve even short-term treatment. They were given medically assisted treatment, and its use largely depends on the diagnosis. The premise between this kind of harm reduction is that individuals will continue to use, so it's better that they use so under supervised conditions in order to limit further harm. And MAT is politically sensitive because it means keeping persons addicted, and even doing so using public dollars in many instances. So MATs includes medications that directly mediate the addictive pathways in the brain or that block these pathways. The three main types of MAT are agonists. So these are the medications that supplant an intoxicating substance and create the same effects as the intoxicating substance. And then there's the antagonist. These drugs either block the neural receptors for intoxicating substances or create other barriers to intoxicating effects. And some drugs have combined agonist and antagonist effects. And I made it in, I believe, 90 minutes. Thank you all for listening, and I hope that you learned a lot, or for many of you, it was a great review. I feel honored that I was able to do this project with all of you and share our work, the fruits of our efforts with all of you. And by all means, please just let us know if we can ever come to your classroom in order to share one of our 15 wonderful modules that we've created. Thank you very much.